Ok, doctor. Muy buenas tardes para todos. Bienvenidos a esta maravillosa tarde con este maravilloso conferencista. Welcome, Dr. Jorg Auer, to this virtual room.
Gracias.
Thank you for accepting. I'm going to make your presentation in Spanish, but don't worry about it. Maybe you don't can understand, but it's a little presentation in Spanish of you.
Muy bien.
Bueno, les comento, bueno, todos lo conocen, pero el doctor Auer se tituló en el año 1974 en la Universidad de Zúrich, de Suiza, con máster en la Universidad de Texas en 1981, en la Universidad College Station en Texas, diplomado del ACBS en 1982, diplomado ECBS en 1983, título de doctor honorario de la Universidad St. Istvan de Budapest. Ha seguido toda una carrera, como ustedes lo saben bien, como cirujano de equinos. En el año 74 fue veterinario residente, en el 74 al 75 asistente del Animal Hospital de Scottsdale, investigador en anestesia equina en la Universidad de Missouri, residente en la Universidad de Pensilvania, Kenneth Square, profesor asistente del Departamento de Medicina y Cirugía de Animales Grandes de la Universidad de Texas, profesor asociado también del Departamento de Medicina y Cirugía de Animales Grandes. Y ha hecho parte también de como director, profesor y director de la Clínica de Cirugía de Veterinaria de la Universidad de Zúrich. Todos sabemos también que el Dr. Jorg Auer es editor del libro más importante en cirugía equina, que es el Equine Surgery.
Exagerato.
Bueno, actualmente es profesor adjunto, parcialmente retirado y de medio tiempo de la Facultad de Medicina Veterinaria de Midwestern University en Glendale, Arizona, Estados Unidos. That's it. Thank you for accepting again and welcome. The room is yours.
Thank you very much. It's a pleasure to be here and to talk to you. I don't know how many you are, but it's always a pleasure to talk to people about things that I like to do. And actually, just about everything you said was correct about me. Okay, now I'm talking about equine fractures today, a little bit of do's and don'ts. I don't have many title slides, just a few words a few times, but it's mainly looking what you find and what you see, and then also make your own ideas and interpretations, what you see, and maybe we can find some solutions to some of the problems. Now, the ulnar fractures, obviously, the most frequent part are kicking injuries of another animal or so. That's because that's an area where there is not much muscle covering the bone. It's one of those areas like on the head and on the inside of the radius, inside of the tibia and so on. And obviously, frequently, if you get those fractures, we find a little bit of a puncture wound like here, as we see, and we always have to figure out, is it an open wound or not? That's what we have to check. Is it going down to the bone, or is it just a superficial skin injury? As you know, the triceps here, it's attaching at the top of the ulna. And when the muscle contracts, it pulls actually what it does, it stabilizes the knee, stretches the knee. But if we have a fracture here, it just pulls the bone apart, but it does not stretch the knee. The typical position of a horse with an ulnar fracture is this, a dropped elbow. It cannot put weight on the knee, not because of pain, just because of the immobility that the knee cannot be stretched. That's the problem, because here the fragment pulls apart. So actually, this is one of the things which is very easy in those cases for stabilizing. If you want to get it to a clinic, you already had that presentation before, but all you need to do, you need to stabilize the knee put a splint down from here all the way down, and the horse afterwards can put weight on the leg. And it is very comfortable at that aspect. So that's why there is one way of treatment, conservative way, just putting on a splint. It depends to some extent where the fracture is. And I'm not going to go into all the different types of fractures that occur, but we look at a few different fractures, and I'm not categorizing or so, just showing examples, what we did, what could have been done better, and maybe what went well and what went wrong. So this is one way to stabilize the fracture, and these horses are very comfortable on it. Just get it down almost to the floor, and the horse can put weight on. The critical part is putting a bandage on over this area. Unfortunately, because it is like a funnel, if you don't go down to the bottom, the bandage with the horses putting weight on and moving the leg will kind of slip down, and maybe that's not going to be very good for the fixation anymore. In this case, not too bad. In other cases, very bad. So what I want you to do when I show you an X-ray of a fracture, in your mind, do a classification and say, is it a simple fracture? Is it a comminuted or multi-fragment fracture? Is it a non-displaced fracture, minimally displaced, or displaced? Is it closed or is it open? Does it have articular involvement, yes or no? Because these factors or these classifications tell you afterwards, to some extent, what you can do when you treat this fracture. Now, obviously, if you have an open fracture, what you're going to have is either gas bubbles under the skin, like we see here, this area, or you may have even some cases the bone sticks through the skin. And this happens when the muscle contracts. So these are things for you to look at. I'm not going to do a test of you and give you a grade on it, but it's for you always good when you see a fracture to look at it in these aspects and see what happens. So if you look a little bit, obviously their management either surgical or non-surgical. And I'm not saying necessarily conservative, because in some cases, conservative may be more expensive because you have a lot of bandage changes, a lot of x-rays, and so on. And that may eventually, if you do a lot, be more expensive than doing actually a treatment of it. Now, the indications for just to consider a horse to do this, if you look at this fracture, is it a simple fracture? Yes. Is it a simple fracture? Yes, it is. It's just a little bit oblique. That's why we see two lines of fracture and another line here. So the fracture is oblique longitudinally. That's why we have one fracture line on one side of the bone and the other is on the other side of the bone. So we have only two fragments in this case. So this is a simple fracture. It is non-displaced in this case. It is not open. We don't see any gas bubbles, but we have some articular involvement right here. That part, the good thing about it here, in this area, the bone of the ulna is not making contact with the bone of the distal radius. But there is a little bit of gap between there. The bone makes contact up here and down here, but in this area not. So obviously that's what this is. And what we need to have is good weight bearing. And this horse, because if the horse stands like this, it doesn't pull the fracture apart, so we have good weight bearing. Basically no displacement. So if we treat this, we need repeated x-rays and see whether it's still in place. And it's worthwhile doing it maybe after 2 weeks. And the other thing, after a sudden change of weight bearing. If the horse was good in weight bearing, all of a sudden it doesn't do it anymore, then most likely we will have displacement. And that's at that point, from that point on, it shouldn't be treated conservatively anymore. It should be treated with implants. So as I said, if you take repeated x-rays, it may get more expensive. Complications of this is we may get a non-union. A fracture doesn't heal. Maybe we get fragment displacement. And in folds, an important aspect is that we may get angular limb deformity in the opposite limb. Because keep in mind, the horse puts a little bit weight on the leg, he puts the main weight on the other opposite front limb, and he places that more under its body. So it's not to the side, but it's more under the center, and in doing so, it stretches the outside of the limb, and if that happens for a long time, we may have an angular limb deformity, a bad one in that leg, and eventually that's going to be the bad leg and the other one heals and it's going to be the good leg. And in adult horses, if there is not good weight bearing, then there will be laminitis. Now, the best fractures to treat conservatively are the fractures that occur below the joint, basically in this area. These areas, they have a pretty good chance of healing if they're in this area and not displacing when the horse is putting tension on the ulna through contracting of the triceps. But that's one thing to keep in mind. And to keep also in mind, this is the tension side of the bone all along here. So that's the ideal place where to put the plate. And the plates are the strongest in tension, the weakest in compression. So if this is the tension side, there's a strong tension side here. So that's a very good plate. It doesn't have to be a very strong plate. So what I want to do now is just look at this X-ray. And this, what can we see? We have, I would just kind of say this is a simple fracture. It's an oblique fracture. That's why we have this. But we do have some displacement right here. We see that gap right here. So there we have some displacement. We don't have any gas bubbles. So I don't think that's a problem. And I do not judge this as having real articular involvement in this case. So would you treat this conservatively or not conservatively? Now this horse was treated conservatively, and this is how it looked after 2 months. Now, if I'm honest, this is it was not one of my cases. I most likely would have gone in and would have put a plate on. But I have to admit, I don't think I would have gotten a better result than this, because we have basically the gap has pretty much filled in. This is after 2 months. We're well ahead of bone healing and it's consolidating nicely. And even another thing we need to look at is up here at the anconeal process. That looks like this is pretty normal. And if we look at this, well, maybe we have a little bit more nose here, but see, this part here goes into the intertrochlear fossa of the distal humerus. And if it's there pushing towards the bone, if it's a little bit oblique, it can cause some arthritis in that area and constant pain as the horse keeps on going. So this, I think, I judge as an excellent treatment, and it worked out well for that horse. This is the next case. Again, the fracture is below the joint, and again, I would say simple fracture. We have displacement, not open fracture, no gas bubbles, and I don't think we have in particular involvement. And this is the case. And looking at it here, after 6 weeks, what can we see? Well, the gap is still here. But what we can see here, along the bone here, we can see callus formation. Now, one thing you have to keep in mind is callus can only deposit on solid bone. So what that happens is it starts building callus on this side and on this side, and more we get a little bit of shadow here. We have made a little bit of cartilage bridging it, and the more callus we get here, the more it's going to come closer to here, the more chances we have that this area will calcify too. And once this part here is bridged, then the gap will heal in nicely. So I think this fracture is well on its way after 6 weeks. Remember, it takes 2 to 3 weeks until we can see some callus. So this fracture is on its way to heal itself conservatively, and the outcome will be good. And again, looking at the anconeal process here, it looks normal. It's in good shape at this point. So, good shape, we're in good shape now. Now, this is an interesting case. Again, looking at it, simple fracture, it has an undulating configuration, as we can see here. It goes around here, goes down, goes up here. But it's not displaced. No open fracture and no articular involvement because the joint is down here. So basically, it is just here, the tension coming up on this area from the triceps. And if it pulls it off, well, the joint is not involved. Yes, we're going to have instability, but not that big of a problem. Yes, we would have to fix it, but nevertheless, so that's a pretty good fixation situation. And looking at it conservatively after radiographs at 6 weeks, again, it is not really, we get a little bit more widening of the fracture gap, but this is normal in that aspect because after a fracture, the ends of the fracture are going to be dissolved by osteoclast, so the gap is getting wider. So from this point here now, yeah, we may have a little more, another fragment here, not a big problem. We're below the joint, and if you go another 6 weeks or 8 weeks, here we are, and it's already consolidating pretty well. We have a little bit of callus formation here. This is where you can see that's where the bone was originally. And now we can see that that callus, and once the whole bone is healed, this callus will resolve according to Wolff's law, which says if you don't use it, it's going to be dissolved. And this bone was important to create the initial bridging, and after that's bridged, that will dissolve again with time. But that's in a very good way. Now, this is another fracture. Again, what we have to look at here is we have I would say a comminuted fracture in this case, because we have a fragment here, we have a gap here, we have a fragment here, this case, and be careful on that. Look where the anconeal process is. That's where it is. So that's never going to attach to the bone. So this case should have never tried to be treated conservatively, because this is what happened 6 weeks later. And you can see the fragment, that callus is still in that anconeal fossa right in here. And it's causing problem. It's going to be moving all the time because it's not solid anymore. It's a piece, it's a fragment that is not attached to anything. So it's basically a joint rat. It's not a joint mouth. It's too big to be a mouse. So this case should have never been treated conservatively. Only we can see, because there is no stability up front in this area anymore, and no stability, so the fragment has pulled forward in this way. And it's not good. That horse is definitely very severely lame, and it should have stopped it maybe at 2 weeks, but not going on for 6 weeks. That's cruel to the horse and not fair to it. So this is kind of conservative treatment, what it does to you, what can happen. Now, all the rest we're talking about from now on is surgical management, because I was a surgeon, so that's what I wanted to do. So here we have treatment. And again, if you look at this fracture, I think you would agree that you would judge it as a complicated comminuted fracture. Well, at this point, we don't have any displacement because we have a plate on, and we don't have an open, well, it was an open fracture because we put a plate on, because at that point, you open a fracture up. That's no question about it, but you do it under sterile conditions. And we have good alignment, good attachment of it. We have good fixation of the plate. Anconeal process is in a good position, and so this is high place. We do have articular involvement, obviously, and after 8 weeks, we have a good result, and it starts healing over, and the fracture is consolidating, and we have won the case. So basically, that's the ideal thing of a fracture and treating it. So what I'm going through now is quite a few cases where we see fractures and see what happens to them and so on. Now, if you want to criticize, and this is always important, I did that all the time with my students and even with my residents. If they did fractures on their own, I told them I wanted to criticize. I want to look at the fracture at the radiograph. And the thing we see here is white or gray on gray or black. What happens? So what we did, you may recognize this, that's an LCP, a locking compression plate. These are locking head screws here, the thick ones. These are Cortex screws. Now the locking head screws, they have a screw head which has threads that go into the plate, and in doing so, they interlock with the plate and are very stable. These ones just press the bone, the plate to the bone. So these are the plates that are placed first in the fixation. We adapt the plate to the bone, put this plate in, and then put this plate in, and maybe this plate, because with this, we can press the plate onto the bone, and afterwards, we put these locking compression plates in, the minimum 2 to 3 on either side of the fracture. In this area, I don't think we would have had a plate hole here and a plate hole here, but we don't really know how this fracture works underneath. And we do not want to end up with the screw in a fracture line. Theoretically, with a locking head screw, we could have tried to get one in. But what you have to keep in mind is when you tighten that screw, you tighten the screw into the plate. And you can do that if you don't have any bone underneath. That plate would feel solid as a rock. So really, we do not know what's happening. If we would be in solid bone, it would be very good to put a plate in because it gives us more stability here. And this is the weak area right here of this plate. Because the only thing bridging here, the plate, the fracture, is the plate. And the bones underneath are moving around. But as you can see, we won the case and we lived happily ever after. Next case, we look at a couple folks. Now, what do you think? Is this normal? I just let you look a little bit and kind of make your idea, kind of interpretation of it. And I'll show you another case. This is the normal configuration of the ulna in a young foal. And all what I did, that place underneath here is cartilage. And this is the apophysis. Now, when you look at this one, you can see it's in a different place. It's pulled forward. So this is an apophyseal fracture and a very difficult fracture to fix. Because if we put in a screw here, with all that cartilage around, we cannot fix it. And it's going to pull right up again, and we have the same problem afterward. So if you want to fix it, we have to do it differently. So we use a plate at the back of the bone and then go over. This is what we feel where we see where the bone ends, but it is actually cartilage. So we place that bone over it, and then we attach a screw in front of the nucleus down into the bone. We could have used a little longer screw. That's okay. But if you just leave it at this, it will not work out. So what we're doing is we're adding cerclage wires in a figure 8 fashion that we make holes right here, around here, another hole here, through the cartilage, in front of the screw, and then we pull the wire through, and then make holes here and here from side to side. And then go ahead and put the wire through here and tighten it at the side in a figure 8 fashion, and then apply the other screws into the rest of the bone. As you can see here, we applied a cancella screw here because that bone is so weak. It is not a strong bone because it has not really was used very much. It's just now adapting to be real strong bone. Also, what we have to keep in mind, we have to stay down here with the screws only in the ulna. Because if we go ahead and put the screw into the bone here, and this one, because it's 3-dimensional, we're only in the ulna, we're not in the radius. But if it would be in the radius, what happens is when the bone grows here on the proximal physis, so what's happening here, normally in a foal that is normal, doesn't have a fracture, the ulna is pulled up along with the growth of the bone at the proximal epiphysis. But if we fix the ulna here, we're going to get a subluxation right here. And I'll show you a case later on. But that's a key element, and up to about 7 months, that's what we have to do. So this is afterwards, 2 days after the surgery, and we can see the plate is in, we see the sutures. Now this is 6 weeks after surgery, sorry. Everything is in place, and here I just show you the fixation at an animal model where we try to fix this in an AO course, where we have a fracture here, we apply a screw down here, and then one over here, and then get our 2 cerclage wires here, and kind of do it in a figure-8 fashion over the bone, have lateral views here, lateral holes, and kind of fix it together so we have circumferentially some solid fixation, and this together is going to hold it so the fracture can heal. I got these x-rays from Dr. Ruggles from Kentucky, and appreciate that he helped me because it's an important thing to show. This is another fracture in a foal, and again what we're seeing, that's about the fracture, and we see another fracture line here, but it is an oblique fracture. So again, just looking at it, we don't see much of a fracture here. We see here a little bit the obliquity, and so it's a simple fracture. It's a non-displaced fracture, and it's relatively close to the joint, but we do not have articular involvement, and it's not open. So from this standpoint, theoretically, it could be maybe tried to be treated conservatively, or we could have just tried to make some holes here and down here and here and here, and then go ahead and have a cerclage wire around here, come through it, go over it like this, and then fix it here, and then another one there. So that would be one way to treat it. Now the other thing, how I treated this is, we just used a simple third tubular plate. It's a very weak plate, a 3.5 millimeter plate, and just put some 3.5 millimeter screws in there. Again, because it is a very weak plate, but it's very strong in tension, it's sufficient in a small animal like this to fix it. And we don't have to do much of an approach, just make a straight incision over the back and put the things in. And again, don't connect to the distal radius, and the fracture healed very, very nicely within a short period of time. And this is, that plate doesn't even have to be removed, because as the foal grows, it will be completely incorporated into the bone. The only reason to remove it would be if you would get an infection. And if you get infections, eventually the plates have to come out. Here we have an adult horse, and one thing, especially at the beginning, it is a very good thing to do to kind of do some pre-op planning. We have a comminuted fracture. I would call this comminuted. I bet it's oblique. I bet we have another fragment in there. We have a little bit of displacement. We have articular involvement here. It's not an open fracture, but it's good if we want to treat it. So it's good to know pretty much how long your screws are. This is a 58 millimeter screw because he doesn't want to go all the way out, because we may get into the anconeal process, which is here. That's because of the X-ray didn't show us that. Now the next screws up here will definitely go up into this area. Here we have an 80 millimeter screw, but that's 80 millimeters, but I don't think we want to put that big a screw in here. We want to maybe end up right here. Again, but it's good to know how long it is from back here to back here. I would never go, if you want to if you want to attach the plate, which is going to come down here to the radius, I will go through the back cortex and stop, because in here, you don't really feel any resistance to your drill. It just goes easily through. Then I would just stop. And I don't have to go all the way through, because if you go all the way through, we really weaken the bone right here, and we would weaken it right here. So all we want to do, if we want to attach it to the radius, we would go through the caudal cortex, not more. And actually, if you want to be a purist in fixation, you just attach it to the ulna and not to the radius. But in a heavy horse, it may be a good idea to attach it there. So this is a pre-op planning, good idea. And then we're going to make our incision. We're going to start on the lateral aspect of the point of the elbow. We don't want to go right over the back of the elbow. We just want to be a little bit on the side, make a turn, and then come down here with our incision. We split the fascia, and then the two muscles, the ulnaris lateralis and the ulnar head of the deep ditch to flexor tendon, and then we can separate it, and here we attach, we're going to find the bone here, and we can see two fractures going across, and then we apply the plate. But keep in mind, this is all what we're seeing. We don't see forward. What we can do, we can maybe feel forward, put a finger in this area under the bone and feel forward. And if there is an anconeal fragment, that's where we're going to would dissect forward, or we would make on the lateral side an incision over that area, go into the cranial aspect of the joint, and remove that fragment. That's important. That should not stay in there unless we can really attach it back to the bone. And then we go ahead and apply our plate here, and there we are. And this is how the fracture looks. This is immediately after the treatment. Now again, we want to be critical. We have the comminution, as we can see here. Yes, there is comminution, and it's good to have a long plate. But again, here, it's the only thing that goes across is the plate. This was in a time when we didn't have locking head plates. So to be critical, I think I would have gone and tried to put screws in here. We didn't want to put a very long one here because we would have entered the joint. So another point that would be critical is we always try to come and get this portion of the bone. This area is the strongest aspect of the proximal ulna. And if you want to put screws in there, that's where we want to be. We want to get that part. And the other point here is this one. What is this? Well, what happened is the surgeon made a hole, and he didn't go into the cranial cortex, but then he went with the tap and he forced it. And when he tapped the hole, he forced it when he had made contact with the cranial cortex, and he broke the tap. Doesn't make a problem. You can still put in a screw, a shorter one, and it's going to be okay. But this is a blemish, and you just don't. If you want to show this X-ray to the owner, you just show it until here and up. Don't show this to the owner. Okay? You always want to be in your But this is what you want to show. Don't show them that part. Maybe the owner doesn't know what it is, so it's not a problem. And this is our horse standing. Maybe for recovery, we put a bandage on, but this part cannot really bandage very well because, again, it's like a funnel. And the movement happens right in this area because it can move the joint. So what we can do, we can maybe tape it with elastic onto the skin. But the good thing here is suture a stent bandage over, and that's going to be solid. We don't necessarily want the horse to get up and down. So what we're going to do is we tie him to with an overhead lead rope with a halter, or give him a short thing so he can't lay down, and give him a hay net. Don't put the hay on the ground. Have him a hay net. And hay nets are good pacifiers for horses because this horse is maybe a couple of days sore, and afterwards he can bear the weight very nicely and is going to be in good shape at all. Still want to keep a catheter in for a couple of days just to have access. Next fracture. What we have here. This is not a simple fracture. As you all saw, we have a little bit of displacement. We have a fragment right here, another fragment up front. We do have articular involvement. We don't have an open fracture. We have a little bit of some potential fracture gaps also here. So this is a critical one, definitely not one to do conservative treatment. Our anchoneal process is okay, in good shape. We have ample bone to put a plate on here. And this is a case where we want to put 2 plates on. One in the back, as you can see here, and then one to the side. This is a broad, both are narrow plates, locking head plates, and we put one to the lateral side, and this gives us quite some stability because if the plate in the back would, because we don't have much stability in this area where the fragments are, would like to bend forward, this plate on the lateral side prevents it because look at this plate is not very wide here, not very thick, but this plate is pretty wide here, and it is very difficult to bend this plate forward and this went this way. So this gives us much more stability in that side. We have to do some more dissection, but this is definitely worthwhile in this case. And that turned out pretty nice. It was a good success. This is an interesting case. We have a fracture, and I call it a simple fracture. It's just an oblique one, but we have these 2 areas. We have displacement, and because here that this is all joint, we do have articular involvement, but we do not have any open fracture. This is actually a relatively frequent fracture in foals because we have the apophysis here, and then it's going to go like this. In foals, we see that relatively frequently. In adult horses, we don't see it very frequently. So this is an exotic case. Now, I mentioned to you that the important aspect in the olecranon is to get the screws up in here. So what we want to do is, basically, and I'll show you on, this would be a fracture in maybe a 1.5-year-old, 2-year-old, we may see a fracture like this. We want to get the fracture here, the screws across, perpendicular to that fracture, but all the way to here. Because again, this is the strongest aspect of here. But because we don't really see the bone in a a clinical case, all we're seeing is the back here. But if we look at this in a specimen, this is an ultrasound polyurethane specimen, we can see we don't have, if we do a little bit of movement to the medial side of the ulna, we may penetrate on the side. And on the X-ray, it looks very nicely, but we're not in the bone. And maybe we don't even cross the fracture line because we end up at the side. So this is very critical what we have to do. And one way to be able to get the screw, that the screw comes, the screw hole comes out here, is we kind of walk off a Steinmann pin underneath the bone all the way to the front, just along the bone, walk it across, and then go ahead and we direct our drill bit parallel to that pin in all directions. In this direction and medial and lateral. And if we do this, we're going to end up right up here with our hole. Is exactly what we want. So we first apply the plate, and then we put a glide hole here all the way to this. Put another glide hole through this hole all the way to this. Because what happens is we haven't tightened the plate yet. It's just in place, but this is still loose. And we're going to feel when we get into the fracture plane with the glide hole. And that's when we stop. And if we did some pre-op planning, we know about how long that hole will be. And when we're there, we're going to be attentive and we feel it. And it's going to wiggle a little bit on the back of this fragment. And we know we're right there. We stop. We do not want to go with the glide hole further forward. So we can have the thread hole here and then cut the threads and make a solid tightment. And then once these screws are tight, we tighten these screws, and then we have a solid fixation. So I'll show you two fixations of pretty much the same fracture. Both of them had a fracture going along this way. Oh no, yeah, this was another side. And here, this fracture went here, and like this. But this is one fracture, and this is the other, two treatments. Okay. Okay. Should I continue?
Cierren los micrófonos.
Por favor, apaguen micrófonos.
Okay. Can you hear me?
Yeah, perfect.
Okay, good. Now, to me, this is sufficient. We don't need to get further. The fracture is up here. We treated it. We got 3 excellent screws all the way up the front. This holds the plate here. These are the only screws we need, and these are just to kind of counteract some shear forces that might have occurred. We stayed basically in the ulna, good treatment. This to me is overkill. We don't need to go all the way down here and have all these screws in here. It makes it a very expensive fixation because the treatment of the more screws we use, the more expensive, and the longer plate we use, the more expensive fracture treatment is. Or we can charge the same amount, but there is more money for us if we use a shorter plate and less screws. So this, to me, is sufficient for this type of a fracture. Now, this is, again, a very complicated fracture. What are we looking at? What do we have? We have a comminuted multi-fragment fracture. we have displacement, we have different fragments, and we have a separated stylo process. And we see here, we don't have any open fracture. So the treatment of this was removal of the bone, of the fragment here. So we have a gap in here, and then have a good fracture here, some good solid screws. We have, unfortunately, there are no locking head screws. It would have been ideal to have 1 or 2 locking head screws here. We don't need all these locking head screws down here. That's too much. But 2 locking head screws down here is ample, sufficient. And because the locking head screws are the expensive part in this part of the treatment. Using 2 locking head screws is sufficient, save the money, and have maybe 2 other screws here, but rather have 2 locking head screws up here. That would have been much more important. Yes, 1 screw we want to have a lag screw, but then, well, actually, this is the lag screw, a 3.5 millimeter lag screw, and then we don't need any more lag screws. We could have used these 2 as locking head screws. And that would have been ample treatment. Came out okay, no problems. But I'm telling you a little bit what I would have done, how I would have used it, what I would have done. Now here we have a different case. This was a radius fracture in a fold, treated, you can see open proximal physis, treated with 1 plate, and in the radius, mid-radius, that's ample. We have nice callus going around, callus going back here. Unfortunately, what happened, it incorporated the ulna. So while this was growing up here, the radius was growing, but the ulna couldn't. And we see this gap here. And what happens here, now this part here contacts with the fossa, the intercondylar fossa of the radius, and this causes some pain, definitely, and if we keep it going, some arthrosis. Now this is still a fold, so and this is actually done in Budapest by Professor Bodo. He called me and said, what should I do? I said, okay, simple. Go ahead, cut the bone, take the plate out and cut the bone. That's what he did. Horse got up, everything went fine, and just by the pull of the triceps, the ulna displaced proximally, and we don't have a gap anymore. Compare this to this, and we have that gap here. The ulna could still slide up, and it kind of prevented further problems. The ulna is in its place, the anconeal process is in its place, and the ulna kind of healed up very nicely. We don't see anything here anymore, and here we see the pony standing straight on the leg, no problem, and being sound. So if this happens, you see it early, simple treatment, and you can continue. Now this is another case, a little more complicated case. It is actually, the ulna broke further down here, which we didn't see here, but this is actually a radius fracture. And it is a type 4 physeal fracture. And what happened is pushed the radius, the caudal fragment, and the ulna backward. So obviously, we have articular involvement. It is a displaced fracture, but it is basically a simple fracture. If you count the fragment down here, it would be a comminuted, that is the fragment on the ulna. But this is what we went ahead and treated it, put a lag screw into the proximal radial epiphysis, and then applied a plate to the back of the ulna to push, or we kind of first pushed the radius, the ulna back onto the radius by applying this plate and using these screws to kind of reconstruct the articular surface. We didn't really get it all the way in. We have some discrepancy here, which is a very difficult thing to do. Yes, we did it on the non-weight bearing, but this is very difficult to do, and we didn't achieve congruent articular surfaces, but we got it somewhat back, and you can see we still have some displacement back here. So we have a little bit of rotation up in here, didn't get it absolutely correct. That's what we got, unfortunately, not an ideal treatment. This horse turned out to be lame afterwards again. Another one, comminuted fracture, not as simple. We have a minimal displacement, articular involvement, no joint involvement, a little bit, we see where the fractures here are, and it was treated with a simple plate. And what we see now that we have it fixed, we can really see that we have quite a lot of fragments here. We didn't use a screw here, we used just a lag screw here, and we used another lag screw here to kind of just reattach these things. But we have quite some area here of gaps, but we're not very happy here. We were hoping this was holding together, but a day later, actually, it had a very rough recovery. And during recovery, we found that we have some abnormal configuration of the ulna at that place. Took an X-ray the next day, and this is what we found. So the plate was intact. So initially we used a 12-hole plate, but that was not enough. When it was a broad plate, it was not a narrow plate. And so we went ahead and treated it again, and we fixed it got a longer plate, 14-hole plate, a 12-hole plate on the lateral aspect, and it took an X-ray the next day. It looked in place, everything fine, but if you're critical, which you always have to be, we found here, we already have a fracture in the lateral plate. It didn't matter. This horse went on and healed it fine, but it could have very easily broken all the way across in the next few days, and then we would have had another catastrophe. But it worked out okay, but it is a difficult surgery to put a plate, such a big plate, from side to side on. All that we had to do quite some separation, especially also at the top where the attachment of the triceps muscle is. Here we have another case, actually a simple, minimally displaced fracture, no articular involvement. And again, this is a case that Dr. Ruggles sent me. I don't think he did a treatment. And this is 2 days post-operatively. And they did a very solid fixation. Yeah, the fracture is here. It is articular. And they really wanted to fix it down here very much. Put a lateral screw, lag screw from lateral here. And this is 2 days, and we see something here which we didn't see before, but it goes to the top of the plate. And actually, we don't have an immediate post-op x-ray. And I think this is something you always should do. Once you fix the fracture on the table, take an x-ray while the horse is still on the table, then you can see, is everything okay? And then what we saw 2 days later, we have a screw that partially pulled back. And then 2 days later, proximal end of the fragment pulled off. So what should have been done? We should have used a longer plate and gone up all the way up to here. Use 2 more screws up here and up here, and we would have been fine and nothing would have happened. But this is a mistake, technical error, which can happen, but we could have prevented that. And now to fix it again is not very good. And this owner didn't want to go ahead and wanted to do a fixation anymore. But just keep that in mind. We have that solid bone all the way to here. Why stop short? And that would have not added much expense to the surgery. Just one more slide on the thing. Now this is a post-op case. It is in a post-op period, but frequently we get infections of fractures. And this one developed that, unfortunately, I don't have a picture of the draining tract that developed, but keep in mind, when we have a draining tract, we have an infected fracture. And frequently, because of the screws, if a screw penetrates the joint or if you have an articular involvement, we may get an infection in the joint. Also, if the fracture is infected, we may get a little bit of lameness, but what happens once, as long as you can drain, and that all the bacteria and the drainage is not kept underneath, keep it draining, let it drain, flush it, and the fracture can heal in the presence of an infection. Keep that in mind. So if you have a long draining tract, what you can do, this is one of those infections, you can do a fistulogram of the draining tract. And what we found in this fistulogram is that basically that the contrast media just stays in this area. It doesn't go along down into the bone. We have actually pretty good healing. So what we would do in this case, don't put the animal under anesthesia, just do a regional nerve block, do some good sedation, and then make stab incisions over that and remove the plates and all the ones that you can do. Most likely this screw you cannot remove, but then, or you may able to do that, and then get the plate out and through the proximal aspect, pull the plate this way, and afterwards drain the area, clean it as much as you can, but we don't open it up all the way. And what happens then, the whole thing will clean out and the infection will subside afterwards and this hole would fill. If we go ahead and put it in under anesthesia, it has happened that while the horse recovers, we get a fracture to one of these screw holes because this definitely weakened the bone in this area. And if it's a little bit of a rough recovery, we may get another fracture there, which we definitely do not want. Well, you were very patient, and I want to thank you for your attention and ask you if you have any questions.
Oh, thank you, doctor. I'm going to see if there is question in the chat. ¿Alguien tiene preguntas que quiera hacer de viva voz en inglés o las quiere escribir para traducirlas?
Yo le quería hacer una pregunta, Mafe, si puede ser, pero espero turno.
Sí, dale. Pregunta.
Hi, Dr. Auer. Thank you so very much for your time and for giving us the opportunity of learning straight from you. It's a great pleasure and an honor. I had two questions to ask you. The first one, I noticed that on many of the repairs, when you use the LCP, there were 5/0 locking head screws on the distal aspect of the plate. Are you concerned at all about a catastrophic fracture of the radius when doing that, or you haven't experienced that in your cases?
Very good point. Yes. See, if you have done treatment long enough, if you said it never happened to me, there are two things. Either you haven't done enough cases or you're lying. So no, it happens. No question, it did. And what happens there is, the main problem is that if you go ahead and you put your plate on too much medially at the ulna, and what happens then, you're gonna come in, and I should have added the slide. I have some slides. I cannot just right away put a thing on it. What happens then is that once if you enter the radius for a long period of time, you may stay within the lateral aspect of the radius and you may weaken it. And this, what this does then, it may cause, it weakens the radius and you may cause a fracture. So the problem is there having too long of a screw hole and having applied the plate too much medial on the radius.
Thank you very much.
If you have to err in the back part, because that back side is very narrow. So if you have to err on the back side of the radius, the way to do is to maybe go a little bit more plate, more on the lateral side, a little bit more on the lateral side. And in the medial side, you have much more bone, and you do not enter the radial cortex. Just the caudal cortex, but not the medial.
Well, what I did is that I started using either just 4/0 locking head screws or just going straight with a cortical screw in those most distal holes of the plate, just to make sure that I wasn't weakening the lateral cortex of the radius. I don't know what you think about it.
Well, that's very good. But most likely what happened is you were in the correct place. You were right at the middle side of the point. You were not too far laterally with the screw. You didn't put it on obliquely. You had it right at the caudal aspect of the radius, and that's fine. At that point, you could have done even a bigger one. But it's better to be cautious and instead of saying, oh, I should have afterwards, once you have a broken radius. But you're doing the right thing. Very good point.
There is a beautiful picture explaining this in the last edition of your book.
Yes, right.
Very clear. And then my last question, I noticed especially on that, oh my God.
If you give me time, I can go to the book and try to get it.
I get it.
Well, I know you get it, but the other guys may want to see it.
Yeah, if you want, it will be my pleasure, absolutely.
Dr. Auer, I have another question.
Yes.
One of this is, if there is any fracture of the ulna that does not require surgery?
Yes. Go ahead, I'm listening.
Maybe could be treated with just cast or rest. It's a possibility of treatment.
Yes, I mean, I showed you a few cases where we did this, where we treated it like that. So yes, it definitely can happen. It could be very good at that point.
Yeah, that was a question of doctor from Mexico. I don't know, Dr. Masri, if you want to speak directly with Dr. Auer. María. No sé si quieras hablar tú directamente también.
I don't find it. No, wait a minute, that's the ulna. No problem. You can ask, I can listen.
Somebody has another question?
Yes, I have a question, Mafe.
Yeah, go ahead.
Dr. Auer, when you need to remove the unconing process because it's a fracture,
I can't get
which
it.
are
Sorry.
your,
Yes.
you
go
got
ahead.
it?
No, I'm listening.
Which are your tips to remove it? Which are your tips to remove the unconing process? I mean, just going through, be parallel to the bone, any tips that you can say?
No, what I would do, I would go ahead, I would maybe with a needle, try to figure out from the lateral aspect, go through the muscles up in front, go right into laterally, right into the joint. From the lateral aspect with a needle, check it with an x-ray if you can, and then make a stab incision into it, get your finger in there and you can feel it. And then with the help of a finger, go ahead and put a clamp in there and get it out. And you just, you do a separate closure of that fracture. That, I think it's easy to do because there is not much muscle there on the lateral aspect.
Perfect.
¿Alguien más tiene alguna pregunta? No sé si ya acabaste, Mauro. Perdón, es que estaba poniendo audífonos.
Sí. No, era para preguntar si tenía algún truco o algo especial.
¿Alguien más quiere preguntar directamente algo? O que le traduzcamos alguna pregunta. Parece que no. ¿O sí?
Mafe,
¿Hay
si nadie
alguien
pregunta,
más?
quiero aprovechar una última pregunta. La doctora Auer, es un privilegio.
Dale, por favor, adelante.
Dr. Auer, just one last question. In that Frison horse, in that case that you presented,
Yes.
So basically, for repair of that comminuted fracture, you went ahead and you kind of bridged the fracture with the plate. I guess taking profit of the fact that it's that basically you're just applying a tension band. That's the purpose of your plate instead of compression or what have you. But then you mentioned that if you would have had locking an LCP in that case, then probably instead of bridging the fracture, you would have actually placed screws into the comminuted fracture of it. Is that right?
Yeah.
Okay, I just wanted to make sure that because I kind of also always, in these cases of the ulnar fractures, I tend to bridge them, just relying on the tension band function of the plate.
Yes.
But you are recommending that if you actually have an LCP to go ahead and to actually place screws even across that comminution.
Well, it's a risk, you know, but well, let me see whether I can go back to that. I can find it. We had a relatively big fragment in that area. So what I wanted to do is no longer presenting. Is that correct? Anyway.
You're presenting.
Oh yeah, I see. I just got a message. There we go. No, let me go out the top. I'm gonna find it first. Okay, that's the case we're talking about. Yeah? We have a relatively big fracture. Now, what to try?
Mape, está tu micrófono abierto.
But get a screw through here, that would have been a good thing. Down here, actually, we could have put a screw here easily. That would have helped just fine. And that would have kind of reduced the fracture at that point. That screw is way too long. That's not necessary. But I could have put a screw, even if a cortex screw I would have put here too. And here a little longer, I would have tried a longer screw, because if you use a locking head screw, keep in mind, it's going to be solid whatever you do. But even if you put in a cortex screw here and it is going to be solid, when you have a really good tight screw, you even do some good on that. So from that standpoint, you're going to be okay. But the problem, the area here, we don't know where we are and how long it's going to be. What this is going to help you is if you do some pre-op planning and you know pretty much where you are, you know about how much that plate would be, how long a screw you would have along a hole, and make it about a centimeter shorter, and you would be in good shape. I don't.
Okay, but
we have.
But you're not concerned about kind of pushing away those smaller fragments when you're drilling or anything like that. Like you're not afraid of destabilizing all those comminuted fragments that are kind of in place as of now, and you're not afraid of placing them.
If I look at this fragment here, it's pretty much wedged in between this line and this line. So it cannot go much in further. On the other hand, at this point, we do not have any articular contact between the ulna and the radius. So if you move a little bit in, I wouldn't be worried too much. But if you would use here a lag screw, kind of just go in, basically drill in first a glide hole into this bone, and then afterwards go ahead and over drill this part, and then use the lag effect to pull this back. I think it would be in good shape. And obviously you can see we have a relatively big fraction, and some of them may be a little bit oblique, but there is a chance you're good.
Okay.
It is a risk. It is a risk, you know. And I think what you're going to do, the more experience you have, the more risky, the more risks you take. Because, yeah, you've been there a couple times.
Thank you very, very much, Dr. Auer.
I don't know if the Dr. Espinosa, do you have any comment? I maybe heard your voice. Indio, ¿me oyes? No sé si te oí a ti ahora o alguien y quería hacer algún comentario. Bueno, Martín, ¿quieres hacer tu pregunta, por favor?
Hey, doctor, can you hear me well?
Dr. Auer, it was great. I have no question. Thank you.
Okay.
Yeah, okay. Well, hi, doctor. My English is very, very basic, but I will try to make me understand, to make me understandable. Well, I had a case some time ago. It was a 3-year-old mare with a complete ulnar fracture and severely displaced with a huge gap between fracture borders. So the horse had been more than 24 hours, and the tricep muscle was making a huge pull force. So So well, that displacement was worsening. So the question is, was it fixable even with that displacement and muscle contraction? I mean, the nerve should be with the limb pulling for a time to relax the triceps muscle before trying to fix it. Finally, the horse was euthanized due to economic reasons. The owner couldn't pay the surgery.
Okay, I'll show you on this case how I interpret what you said. By the way, your English is much better than my Spanish, okay? You're doing well. So what I would say, you had a fracture here, and the fragment was, I need to get the pen in, just a moment. Oh. The fragment, we had a gap maybe that big. But this was a gap between the proximal and the distal end. And a lot of times, you know, when we have the horse in lateral recumbency, when the horse is standing, when we take an X-ray, we pull the leg forward, and then we get a very big gap. Otherwise, we cannot get the ulna on the X-ray. Okay? So when we put the horse on the table, what we're going to do is we pull the leg backwards. And what that does, it reduces our fracture.
Oh well. So the X-ray could be with a false interpretation due to the standing position.
Well, because the standing and taking the X-ray, to get the X-ray, you have to pull the leg forward. And, and in doing so, if the fracture is completely through and completely detached from the top part, then it pulls up, and you don't have to. And you think, oh, that gap I can never close. But if you put the horse on the table, there's no tension on it, and pull the leg back, it reduces on its own.
Oh, well.
And you're going to be behind the horse. So if you see that again, it is definitely fixable. And this is an easy thing to do. And a lot of times people are afraid, oh, that gap I can never close. But this gap, if it's that big, it would never heal on its own. So even if it's a month old or 2 months old, it still is movable. And at that point, do this and reduce it, and you can put a plate on, you're fine.
Oh, well. Well, thank you, doctor.
You're welcome.
Anybody else has another question? Of course, Dr. Duque, go ahead.
Hi, Dr. Auer, how are you?
Doing good. Good to talk to you.
Okay. Doctor, I got a question. I had a fall like 2-3 weeks ago who had an accident. He had an open, a little bit displaced fracture, but the accident was like 3 days before we saw this fall. So the thing is, when we saw the fall, there was pus coming outside the wound. So we decided to just treat this fall medically, antibiotics, cleaning the wound, and we decided to wait like for 2 weeks before deciding to put in a plate or not. So the question is this a good way to do it, or what else?
How's the fall doing?
Okay.
How
It's
is
doing
right now?
yeah, it's doing very well. After 3 weeks, it's starting to put more weight, and so far I don't have a X-rays control X-rays, but it's doing well. It's putting weight. So we just put antibiotics and we put a splint and the bandage, as you mentioned, and is doing well. So
Okay. My suggestion to you at this point is take an X-ray, look at it how it looks, and if there is not much displacement and the fall is doing okay, I might as well go conservative, because you may exacerbate the whole thing into a severe infection if you put implants in now. What I would do also is maybe put a splint on the other leg, so you don't get the angular deformity in the other leg. You may have to help them to move around a little bit, and once it's consolidating, the fracture is doing better and better, well, then you may not need the other thing. But as long as it's lame and favors the fractured leg and the infected leg, I will go on like this, because I think you did the right thing. It was a very good thing you did, because we have, as you all know, we have a 6-hour period in doing when we get when the fracture occurs, and if you can treat it, an open fracture within 6 hours, we have a very good chance that we don't get an infected fracture if you debride it properly, treat it well, and antibiotics right away. So we would have a chance there. But if it's 3 days old, and you said you had already pus going through, there's no reason to go in and and put an implant in at that point. And if it's now getting better, and if you see you have a good fracture, good alignment, relative good alignment, you can send me a copy of the X-ray, and I give you advice then. That's no problem. You have my email, and I gladly look at the X-ray once you've done it. But that's what I would take now, an X-ray, and see how it's going.
okay, doctor, thank you very much.
You're welcome.
Doctor, I have a question of Dr. Ivan, an Argentine surgeon. He asks do you use any external fixation or caution for the recovery from the anesthetic?
External coaptation? Well, I think the problem with external coaptation is that we alter the tension side and of the whole limb if you put a splint on the back of the leg. And the other thing is we have a very long limb that cannot bend. So if the animal gets in a wrong position, something else may happen and we may get another problem. If it is a comminuted fracture of the ulna, and I just put one plate on the back, maybe for the recovery, putting on a splint and helping the horse in the recovery with a head and a tail rope, that would be maybe good. Obviously, we had the luxury to have the swimming pool to put the horses in a recovery, so I didn't have to put any weight on it until it was standing. But otherwise, in a comminuted fracture, maybe that's a good thing, but then help the horse with head and tail rope to hopefully have a smooth recovery. And afterwards, once he's solid and standing well, remove that one.
Okay, thank you again, doctor. And I think that's it. Or maybe anyone else has another question? If not, I just have to say thank you again. Thank you for your time, for your awesome conference, for your kindness. And as soon as possible, we hope to have you here. Oh, sorry. Sorry, just wait a minute, because just in this moment, I received a question.
Okay.
How do you manage possible laminitis in the limbs, based in your experience. What is your experience about the incidence of presentation of laminitis in the postoperative period?
Okay, yeah. Laminitis is a tricky thing. In my opinion, there are two types of laminitis. Some of them respond to treatment and some of them never respond to treatment. And I don't know ahead of time which ones are which. That's just my personal opinion of it. But to prevent it, it is difficult again. Obviously, if you do a good fixation and the horse is putting weight on the limb afterwards, uses the limb, the chances of developing laminitis in the post-op period is very minimal. The problem of laminitis you get then when the horse is sore and doesn't use the injured limb very well, puts most of the leg weight on the other leg for a prolonged period of time. But then again, there may be one, the horse is doing pretty well, but not much lameness, and he develops it. That's again, that's the freak thing, you can never predict it. On the other hand, I would say you have the greater chance of post-op laminitis in the conservative treatment, because there the lameness, it proceeds longer, and so that's the bigger chance to get laminitis. So what you need to do if you do that, obviously give them anti-inflammatories. Don't kill them, don't put too much on it, but just take the tip of the pain away so they can tolerate it. And horses, especially athletes, race horses, and all athletes, they are used to pain. They tolerate pain much more than a show horse or a horse that is only used at halter. These are wimps, and once they have a little bit of pain, they crumble and they want to die, and they cannot tolerate pain, so they are the more likely to develop something like this. And but horses that are athletes, they tolerate pain much more, and so you have a bigger or less of a chance to develop it.
Okay, doctor, I have another question, and that's not related to ulna fractures, but there is a doctor that wants to know if what's your experience, which is your experience in neck fractures, in ilium fractures, and in tabulum fractures, and what is the prognosis, the sport prognosis?
Well, ilium fractures, I don't think they're very big of a problem because there is no articular involvement. If there is articular involvement, the prognosis is not very well. Therefore, acetabular fractures, I think the only chance you have is in a foal. In an adult horse, I don't think there's a chance. In ilium fractures, if you have, you can go ahead and you can apply some plates, and we have some of it in the newest edition of equine surgery. There, Dr. Richardson discussed that to some extent, but acetabular fractures, I don't think we have a chance. And it's better than to kind of not to put good money after bad and try something, because most likely the result is not going to be success. Foals, they always have a bigger chance to success, and depending how the foal tolerates it, and if there is not much displacement and just a green stick fracture into a joint, and it's not going to be displaced, maybe it can heal. And again, foals can heal much faster, and they have a greater chance and greater potential of regeneration, also of cartilage, minor cartilage damage.
Okay, thank you again, doctor. I think there is no more questions. Now it's again time to say thank you. and say that we hope to have you here soon as possible for you and for us. And it was a pleasure to see you again, virtually, but to see you again, it was a real pleasure.
Thank you very much. I enjoyed it. It's always fun to talk to people and interesting people, very good questions, and I appreciate it and hope to see you in the future. That's good.
Okay, thank you, doctor. Have a nice night.
Oh, it's afternoon. It's getting ready to
Bye
have a
bye.
little after.
I sent a kiss, a hug.
A little bit apero.
Bye bye, doctor.
A little bit Malbec.
Thank you
Gracias,
very much,
doctor.
Dr. Auer.
You're welcome. I enjoyed it.
Gracias.
Gracias, Mauro, por la conexión. Gracias, Mafe. Perfecto lo tuyo. Saludos, comunidad.
Che, Puchito.